Greetings and welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA.
Hello, today we are going to have a discussion on iron metabolism and its role in erythropoiesis in MDS. And we're lucky to have two experts in the field here, Yelena Ginzburg and Amit Verma. And please, Yelena and Amit, will you please introduce yourself?
I'm a physician scientist at the Icahn School of Medicine at Mount Sinai in New York. I study iron biology in the laboratory and its crosstalk with erythropoiesis, both in normal and dysregulated conditions. And I see patients in the iron disorders and erythropoiesis disorders spectrum, both anemia and polycythemia there.
Yes, thank you. And Amit?
Good morning. Amit Verma. I'm at the Albert Einstein College of Medicine and Montefiore Medical Center. I work in MDS, both clinically and in the lab, and we have worked on the role of various oncogenes, stem cell alterations, and iron overload in MDS models.
Thank you very much. So I think just to get started, because we are different types of people listening here, so I think I would like to start with the clinical question. So in which patients would you actually, MDS patients, would you recommend iron chelation? And how do you consider that with respect to the effects and the cost and so on? How would you prioritize? Do you have an opinion on this?
Yeah, I can start and take a stab at this. So MDS patients can broadly be grouped into two major categories: a lower risk form of MDS and a higher risk form. The lower risk patients mainly suffer from low blood counts, and anemia is the predominant clinical presentation, which affects 95% of patients with MDS. We have some drugs that help with anemia, but none of these are curative, and most patients relapse. So transfusions becomes a mainstay of treatment for these patients. And with transfusions, these patients develop iron overload. So iron overload is a big problem for MDS clinicians. And in lower and intermediate risk patients, we have this problem very significantly. We face this problem because of the need for transfusion dependence. So iron chelation does present a very attractive therapeutic modality, especially for lower risk patients, because these patients are going to be dependent on transfusions for many, many years, and they face prospects of end organ damage from iron overload.
Yep. So it gives us an opportunity also to discuss how to select patients for iron chelation. And so firstly, one would need to consider the diagnosis of iron overload, which of these patients are iron overloaded and which less so, and the standard discussion in the clinical field. And Amit, please also add that transfusions in the range of 20 or a ferritin above 1,000 tend to be clinical markers that are easily accessible. And in the centers where MRI is available or other more specific modalities that allow us to directly measure organ iron concentrations, these become more attractive direct measures to diagnose iron overload when they are available. And then the other are things like life expectancy, and the expectation of survival for 1 to 2 years is the minimum to bring up this therapeutic modality to attempt to treat these patients.
Yeah, I think this is also what I'm sort of used to. I think we have slightly higher limits, like 1,500 for ferritin, but also the 2 years life expectancy. What about, do you have any age limit to when you iron chelate?
MDS is a disease that predominantly affects the elderly. So we don't, in our practice, we don't necessarily have any age limits. The chelating agents are generally well tolerated. You know, they are associated with some side effects, which we can talk about, but they are generally well tolerated, especially when given in the oral form. So we don't really have an age limit for their use.
What is the major side effect that you worry about actually with these drugs?
Yeah, so you have to be careful that you're not dosing patients who have renal compromise. And also, some formulations may have some gastrointestinal side effects and may also be associated with a dry mouth. Some newer formulations do have less of these side effects, but generally, overall, they're well tolerated.
Yeah.
So it gives us an opportunity to kind of go through the list, perhaps. There are 3, 4 approved oral iron chelators, at least in the US. There's desferal, the parenteral administration. There's deferiprone, which is an oral agent dosed 3 times a day, which is not approved for MDS at the moment, as well as deferoxirax. And that is dosed once a day. And I think, Amit, that's the one you were already alluding to. Deferoxirax in its 2 formulations, one with the gastrointestinal added benefit of lower side effects, as well as the original one.
Yeah. So do you experience good compliance with these drugs? Is that the same for all 3 formulations? Because I think that's important. I think since patients are having this for a long, long time, compliance become more and more.
That's a very important question. We generally don't have problems with compliance. These patients do understand that iron overload can be deleterious to their health. The pills are relatively easy to take. That's the mainstay of our treatment in our clinics presently. And we don't have major problems with compliance. The issue is the efficacy. You know, the problem is if a patient is transfusion dependent and is on a regular transfusion schedule, for example, gets 2 units of RBCs every 2 weeks, they get a massive iron overload every time they get a transfusion.
Exactly.
And the iron chelators do work, but they work quite gradually. So you have a slight decrease with sustained dosing, and then suddenly you get a transfusion, and then it goes up again. So overall, it's, you know, a tough problem to solve because these agents do work, but they don't work dramatically rapidly.
Exactly. Yeah, that's very important to think of also when you treat as a physician. Maybe we should. So you have touched upon the low risk MDS. Are there any situations where iron chelation is recommended in high risk, or where you would recommend the iron chelation in high risk?
Now, high-risk patients, the main problem for them is transformation to acute leukemia. So the goals of therapy become how can we prevent this transformation to acute leukemia phenotypes? And the mainstay of treatment presently in the US includes hypomethylating agents, decitabine and azacitidine. The BCL2 inhibitor venetoclax is being used, even though the phase 3 trial, we are still waiting for the results, but it's being used. And the goals of therapy, as I mentioned, are improving overall survival, reducing the blast count, and eventually preventing the transformation to acute myeloid leukemia.
Yeah.
The patients that respond to these agents, we do get a good response duration, and then iron becomes important. So I would say in the acute setting, where you're worried about blast transformation, iron may take a backseat, iron chelation may take a backseat. But as these patients respond to therapies, iron overload does become important. And one emerging issue in these patients is if they have bone marrows that are quite heavily iron overloaded, there is science that shows that they have an increased amount of reactive oxygen species. And these and other iron metabolic products may actually accelerate the condition, may actually make the transformation to leukemia, may make cytopenias worse. So iron chelation may actually help with that. So scientifically, it makes perfect sense to do iron chelation even for high-risk disease, but it has not been borne out yet in big phase 3 trials.
Just to add to that, there is also some emerging data that correlatory that the outcomes of transplant, stem cell transplant, are worse in heavily iron-loaded patients. And I mentioned the word correlation because the more severe the disease, the higher the transfusion burden, the higher the likelihood of iron overload. And the question still remains, if you controlled that iron overload, whether transplant outcomes would in fact be improved. But that concept is an important one to look at, as Amit is saying, whether the iron overload itself is contributing in the niche, in the bone marrow niche, that contributes to worse transplant outcomes in the patients who are eligible.
Yeah, Dr. Ginzburg brings up a very important point. You know, there are a bunch of studies that have shown that iron overload is associated with adverse outcomes post-transplantation. And the few patients with MDS that we can actually offer an allogeneic transplant and a curative therapy with an allogeneic transplant, this becomes an extremely important point.
Yeah. That is also how we look at it here, I think. So transplantation, and of course the low risk that really needs transfusion for years. That's the main. Yeah. Okay. So of course, one of the major concerns we have about iron is that the organ damage. Why does that happen, and what are the consequences, and please elaborate a bit on that.
Sure, I can give you a clinical perspective, and Dr. Ginzburg can elaborate on this. These patients with MDS who are iron overloaded are generally, elderly, and they do have comorbidities that include heart conditions, liver conditions, kidney conditions. Iron overload can particularly affect the heart as well as the liver. So we encounter situations where patients may develop progressive heart failure. We also encounter conditions where liver function tests may become abnormal. And both of these have a big impact on the patient's, total outcomes as well as prognosis.
And how do you follow that? Because now you say, is it so gradually that you can actually just wait and follow the heart condition, or do you really need to be aware that
No, it's a very important point. We usually do echocardiograms to assess for contractility and ejection fractions. But a lot of times the patients present with symptoms of, heart morbidity, and that may be, features of heart failure, but also chest pain, which the anemia doesn't help, right? And also, some fatigue, loss of quality of life. All of these may be linked with slowly progressive heart failure.
Yeah, so it's so maybe do we have to follow them regularly, you think, or can we just wait until the symptoms are there, or how do you see it?
So, as Dr. Ginzburg mentioned, if we have a high ferritin and a patient is transfusion dependent, we usually start them on chelation in our practice, especially in low intermediate 1 patients.
Yeah.
And we do the heart checkups as needed if they start showing symptoms.
Yeah.
You are treating them with chelation, so you're doing what you can. And, if they do develop symptoms of heart failure, then you push the chelation even more aggressively if possible.
Exactly.
The liver, though, is usually the first organ to get loaded, and at least from thalassemia literature, the the heart is rarely the first loaded organ, but I think what Dr. Verma is saying is that many of them will have evidence of liver iron overload, and then the cardiac symptoms are overlaid more after iron overload progresses over time, and that becomes a new plateau that really does require pushing iron chelation to its maximal effect, because the lower level is attempting, perhaps unsuccessfully, to manage at least the liver iron loading, which we follow with pretty standard blood tests for ALT, AST, and synthetic function.
And you also sometimes do fibroscans, don't you? Or do you use other kinds of scannings or things for looking at the iron levels?
My personal preference is MRI. That really allows you a quantitative measure over time to see if you're progressing iron overload, decreasing iron overload, or steady prevention of exacerbation of iron overload in the liver. But I think your point may be also about how do you look at the consequence of the iron loading in the organ, and sure, fibroscans would be one additional way.
So I remember one younger patient with bad compliance who actually came into the ward. You know, we did on an echo a few weeks before, and he comes in with a complete heart failure, 10% EF. And it's actually, what I remember there was, it was actually possible to draw out all the iron again by using high doses of intravenous desferal. So I think, you know, it's important to understand that this is a reversible, to at least to some extent, also in the severe cases, reversible condition.
Absolutely, but it's quite acute, and so one wouldn't want to wait until
No, it was awful.
Right. One wouldn't want to wait until these peak exacerbations to initiate therapy.
Absolutely not. Good. How do you, so can you explain a little bit more detail how this iron overload pushes the inefficient hematopoiesis? Because that's, for me, a little bit more complicated to understand. And I wish we had some slides here, actually, because I think we're digging into some very complicated mechanisms. And maybe you can explain that.
Well, I can try. So the general consensus is that iron overload correlates with ineffective erythropoiesis. And this is partly due to the consequence of, again, high transfusion requiring patients being those that load iron most, with the correlated increased morbidity and mortality of the iron overload that we've already been talking about. What we don't know is whether iron overload also directly worsens ineffective erythropoiesis, and Dr. Verma already started alluding to these partially known elements, like the in vitro work and the mouse work that has been done that has shown that both iron overloaded serum in patients can suppress the proliferation of erythroid early progenitors in vitro, and that mouse models with iron overload are correlated with worse anemia and chromosomal instability in vivo as well as in vitro. So there, and then of course there's iron chelation data that both in prospective and retrospective studies that has shown that there is a subgroup of patients who can increase their hemoglobin and decrease their transfusion requirements when treated with iron chelation. So, but what makes the responders different from the non-responders is poorly understood. And the randomized controlled trial using deferosirax, the Telesto trial, actually did not show a decrease in transfusion requirements and an increase in hemoglobin in low and intermediate risk MDS patients. So there is data that is incompletely, doesn't show a complete picture yet about both whether and how iron overload impacts ineffective erythropoiesis.
Because there are certain pathways you have been looking into, right? Could you just quickly say a few words about which pathways are important here? I mean,
Dr. Verma?
So MDS, the main problem in MDS, as Dr. Ginzburg said, is ineffective hematopoiesis, predominantly erythropoiesis, but also myelopoiesis. So the patients have low blood counts. We have, and others have studied, the molecular pathways that may cause this block in differentiation and suppression of normal hematopoiesis. And there's a lot of inflammatory pathways involved in this problem. And one of the pathways that's involved in this is the transforming growth factor beta pathways, the TGF beta pathways. We and others have shown that TGF beta signaling, namely SMAD signaling, is overactivated in MDS bone marrows. And when you interrupt that, you can relieve the differentiation blocks and cause increases in blood counts, at least in experimental models. And there's emerging data that iron overload may also interfere in this process via different mechanisms. So there are, investigational papers that show that iron overload can increase reactive oxygen species, which can be damaging, lead to chromosomal instabilities, like Dr. Ginzburg mentioned, but also there are pathways involving mediators such as hepcidin, and Dr. Ginzburg can elaborate more on that, that can also modulate the SMAD signaling pathways and thus lead to further bone marrow suppression.
Yeah, that's what I sort of was thinking you would talk about. So maybe, Dr. Ginzburg, could you please tell us a little bit about this?
So Dr. Verma and I recently published a paper looking at the effects of differapone, specifically the iron chelator differapone, in a myelodysplastic syndrome mouse model, the one that's extensively used, sort of the favorite model in the field, that showed that we could target how iron is delivered and trafficked and sensed within the erythroblast. So we can see that differapone decreases reactive oxygen species, specifically in erythroblasts. We can see that it changes the delivery of iron, transferrin-bound iron, to the erythron. And we hypothesize that iron chelation as a group, of course, all lower ferritin and iron loading in the parenchyma, but the affinity of the iron to the chelator may be additionally important, so that rather than binding iron and removing iron, which they all do, the goal may be rather to bind iron, remove it from an intracellular compartment, and deliver it to transferrin, with now emerging data that the kind of transferrin that is found in circulation when bound to transferrin receptors on erythroblasts can alter the EPO responsiveness in a different way. And so modulating specifically the compartment in which that iron is contained and how it's delivered can alter how the erythroblasts themselves proliferate, differentiate, and apoptose as a consequence.
Very interesting. So will that sort of be a new target for therapy, you think, or can that be modulated in some way?
Well, we're certainly aiming in that direction, but this is preliminary mouse data, and it requires being viewed in that context, that this is, we're not by any means suggesting that we have novel therapy, but I think it opens a door for a deeper understanding, perhaps, for how iron chelation in a subset of patients does, in fact, reverse ineffective erythropoiesis in low and intermediate risk MDS.
That's very interesting. Yeah. So about your mouse model, can you just elaborate a little bit on that? So I know you say it's the most commonly used, but it's also develops into AML quite quickly. Is that correct? So
Yes.
it's really a good model for low risk MDS.
It's a very important question. Therefore it allows us the opportunity to look at a early phase as well as a later phase. So the literature suggests that the mouse model transforms, and not in all cases, but the likelihood of transformation increases at the 7-month mark, which is about half the life expectancy of a normal mouse. And so then, therefore, we analyze our animals at the 5 and 6 month mark prior to the transformation to AML. Another caveat that is a vagary of animal models is these are not transfusion-dependent mice. And it is also true in MDS that prior to transfusion, the mechanism of the communication between ineffective erythropoiesis and iron metabolism leads to an iron overload phenotype that can be observed most clearly in the ring sideroblast subtypes of MDS, but is occurring in all the different IPSS categories. So that this mouse model mimics in some ways the earlier phases of MDS, the less severe forms, and in other ways the more severe forms, and can be used as a model, not in a vacuum of other kinds of data, but to for discovery and for testing.
So what is the genetic defect in that mouse? I forgot about that.
It's called the NUP-HOX3 model. Dr. Verma, do you recall offhand?
Yeah. This is a translocation between NHD13 and HOX. This is a genetic defect that's seen in some patients with MDS. It's predominantly seen more in pediatric cases.
Yeah.
But we do see some adults with this particular
so it's not the classical MDS defects that we know. No, because it's very difficult with mouse models in MDS, isn't that correct?
Absolutely. So that's a very important point. We do not have great mouse models that recapitulate the phenotype of MDS, and this probably is one of the best ones to model MDS in vivo setting.
Very interesting. Yeah. So so based on all this, do you think we talked about a little bit before, you might think about new targets for iron chelation or new targets for MDS therapy? I think it's two different things maybe, but still, if this really does improve hematopoiesis, so do you think we can come up with new suggestions, not now maybe, but in time? With time, new suggestions for treatment? Do you foresee any new treatment in low-risk MDS? Because low-risk MDS is really difficult.
Yeah. So there's a lot of research happening right now. I can give you a very brief treatment landscape of low-risk MDS. So we have the erythropoietin-based treatments, which can include EPO as well as the long-acting form, which is known as Aranesp. These are used for patients that have a low baseline EPO. We also have Revlimid, which is lenalidomide, which is only used for patients with 5q minus deletion. And then we have luspatercept, which was initially approved for patients with refractory anemia with ring sideroblasts or with an SF3B1 splicing mutation, but now has a broader approval for MDS for all subtypes. And very recently, a drug called imelostat, which is a telomerase inhibitor, was also approved by the FDA. That being said, the hypomethylating agents, decitabine and azacitidine, are also sometimes used by clinicians. and maybe in slightly lower regimens, lower intensity regimens than what we use for aggressive MDS. But that's basically the treatment landscape. There's a lot of research going on, and patients, PIs are trying a lot of investigational therapies that are being used in trials that are targeting inflammation, cytokine signaling, as well as the inflammasome. But we don't really have robust clinical results yet. So these are not FDA approved.
No, so
I also think that the targeting of ineffective erythropoiesis is really the niche, more so than direct iron chelation. If we're going to research how to manipulate iron, it would be only, from my perspective, with an eye towards the communication between the erythroid compartment and the iron metabolism compartment, because the real target is ineffective erythropoiesis. The chelators that we currently have are doing a great job chelating. Can we push them to be more potent so that we can more effectively decrease the iron load of the transfusion burden? Of course, that would be a wonderful unmet need, but I would still venture that targeting the ineffective erythropoiesis directly to enable avoiding transfusion or reducing transfusion burden would be the direction that I would take for development in the field.
Yeah, that sounds like a very good way to go, I think. Yeah, because we've been doing the other thing for many, many years, actually, and this is probably where there is something that can also improve the disease itself. So that sounds nice. Yeah. So do you think, are there any important questions we haven't touched upon that you would like to discuss? Yeah.
I think you've done a great job bringing out the important clinical and translational issues with iron chelation. It continues to be a very big problem, and a problem that's not easy to fix in our field. So I would encourage, scientists and industry to come up with better and more powerful solutions for iron chelation, because it continues to be a massive unmet need in our patient population.
Exactly, and it's a growing patient population, really. So
yes.
And do you have something to add, Yelena?
I think you've done a great job. I'm very happy.
Very good. But then I want to thank you, both of you, Dr. Ginzburg and Dr. Verma, for taking the time. And on behalf of EHA, I really want to thank you for participating in this very interesting discussion. So thank you very much.
Thank you.
Thank you, Dr. Grønbæk.